I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is optimizing medical therapy. But first, let me introduce my co-host, Dr. Dan McCarter. Dr. Dan.
Hey, Faisel. It's great to be with you this evening. Looking forward to working in the chat and answering questions this evening.
That's my favorite part. Actually, of course, I love speaking with the experts and talking with them and learning from them. But also, I love the interactions. I mean, you just never know where people join in from. And I enjoy that as well. So without any further ado, Dr. Bill Besterman, thank you so much for joining us this evening.
Glad to be here.
I first heard you speak at a CARES 1 presentation with Dr. Grundy. And I knew from that moment that this is someone that I need to connect with. And I'm so grateful to Dr. Grundy for making the introduction.
I'm absolutely grateful and glad to be here.
Well, Dr. Besterman, I'd like to ask you a question. When we're talking about optimizing medical therapy, many residents, many young doctors are now learning about medication management being superior or the same as interventions. But I'd like to take us back. I'd like to take us back to the history before all these interventions. And then if you can kind of walk us through how that change happened. And then also some of the steps you took to address population management in a common sense manner.
All right. Well, I guess it was about 1980 that I went to a small town in South Carolina, Beaufort, South Carolina. Very small hospital. We were an hour from any ICU. Half the people were dying of heart attacks and strokes. And we didn't have an ICU, and so we had to start one from scratch. It was a very small hospital. And since half the people were dying of heart attacks and strokes, and I was an internist, I was the guy with the most training in those conditions, and I just got thrown into it. I really hadn't realized that was what was going to happen. And I faced many families that I knew with bad news, which was heartbreaking. And that drove me to really be interested in this topic. And I literally I evolved into practicing effectively preventive cardiology. And I referred many patients, hundreds of patients, to have revascularization. And then in 1995, I read this article from Dr. Peter Libby at Harvard saying, really, heart attack is all about plaque rupture that may occur in an artery that was totally unblocked prior to the rupture. It causes a clot. And so a stent or bypass prior to that event isn't going to make any difference. And so going way back in 1995, we knew that only 14% of heart attacks occur in an artery that's more than 70% blocked. And that's what you got to have to justify a bypass or a stent. Well, that knocked me over. I mean, I felt so badly because I had sent so many people to have those procedures. And honestly, some of them hadn't done that well. So I really felt bad. And with that, I really began to think about what is optimal medical therapy? What would the components be? It turns out it's best practice management of blood pressure, lipids, and diabetes. And so, that was a real challenge because nobody was really thinking that way then. And then in 2008, the Courage trial came out. That was the first of the big studies that really proved that optimal medical therapy alone in stable angina patients is just as good as optimal medical therapy plus a stent. And since that time, there have been 15 studies that affirm those findings. The latest one was the ischemia trial, and both Dr. Marone from the ischemia trial and Dr. Bowden from the Courage trial 5 years ago wrote that optimal medical therapy should be a universal standard of care in cardiology. And I agree with that because I think all the evidence shows that that's the way it should be. And strangely enough, there aren't that many optimal medical therapy studies other than in this section of cardiology. And there aren't that many people doing optimal medical therapy. So optimal medical therapy is evidence-based practice consistent with best practices. And that's compared with usual care. Well, at Kaiser Permanente, they actually did an optimal medical therapy trial in people who had had a heart attack. So these are very high-risk people.
Sure.
And half the group got optimal medical therapy managed by one of those Kaiser teams, and half of them were in the same building getting usual care, just what everybody does in the broader community, right? Well, over 4.5 years, the optimal therapy people saved $21,900 per patient per year, and mortality was reduced 90%. There was a diabetes trial done in Denmark, same thing. What marked the patients as high risk was they had chronic kidney disease. And that's such a potent risk factor that people who have chronic kidney disease and diabetes usually don't live to be on dialysis because they die of heart attacks and strokes. So it's very high risk. And it was really remarkable so the intervention period between optimal therapy and usual care was 8 years.
Wow.
The differences at that point were so striking, everybody went on optimal therapy. But even at that, at the 13-year mark, the usual care crowd had 4 times as many heart attacks, 5 times as many strokes, 6 times as many went on dialysis. And at 13 years, half the usual care people were dead. Their average age was 68. So the evidence just kept building. And by now on that study, they have 21 years of follow-up, which shows that they delayed cardiovascular events by 8 years and prolonged life by 8 years compared with usual care. So, I have to ask myself the question, why isn't this a universal standard of care? Why are we still doing usual care? Why aren't we using protocols and systems and teams to get this done? So I really, I'm serious about it. So